A very good afternoon to all our viewers. I, Dr. Siri Kamath, Senior Consultant Physician, Internal Medicine and COVID Task Force Co-Charge, would like to welcome you all to today's session, COVID Demystified. COVID as a disease, I think, needs introduction no longer. Our world has been battling this pandemic for more than a year now, and in its wake, this tiny virus has left great disaster. The total number of cases today stands at 16.9 crores worldwide and a death toll of 35 lakhs plus. Over the last year, it has also become very clear that there is such a plethora of information, so much surplus information, that it becomes difficult sometimes to keep track of what is relevant to us. So the purpose of this today's talk was to have factual discussion so that there is a clarity among viewers regarding some important aspects of the disease as it pertains to them. So before taking this discussion forward, I'd like to introduce all my esteemed colleagues who are also my panelists today. Dr. Sandeep, Interventional Pulmonologist, Consultant Interventional Pulmonologist and COVID Task Force Co-in-charge. Hello, Dr. Sandeep. Dr. Vishwanath Bellad, Consultant Pulmonologist and COVID Task Force in charge, who is unable to join us today due to some unforeseen circumstances. Dr. Gauri Shankar, Consultant Intensivist, MICU and COVID ICU, and also COVID Task Force in charge. So good afternoon, sir. Welcome to the discussion.
Good afternoon, madam. Good afternoon to everyone.
Dr. Balakrishna, Senior Consultant in Internal Medicine, VGS Hospital. Good afternoon, sir. So taking this discussion forward, Dr. Sandeep, would you like to shed some light on what is this virus exactly? And at the end of a year, what is the consensus on what is the most important mode of spread of this disease?
Yeah, thanks for the kind introduction, Dr. Siri. And as you told, I think the whole purpose of this, Facebook Live is to demystify the COVID-19 infection. There is a lot of information which is flowing across the Facebook, throughout internet. It is flooded with information on COVID-19. But what is right for us, what we should take and what we should not, is the thing which we are going to understand by the end of this Facebook Live session. So just to give an introduction, as you all know, COVID-19 is a viral infection caused by novel coronavirus, which started its journey from Wuhan in 2019, and now it has almost infected every nook and corner of the world. So that is the causative agent of this particular infection. And coming to the mode of spread, initially we had a lot of misconceptions that there is a fomite spread and the surface spread and all those things. But now, for all practical purposes, it is majorly a droplet infection, and there could be some airborne infection also. That these two are the accepted modes of infection of COVID-19 viral infection. So you need not worry about your newspapers. You need not worry about your lift buttons and your door handles and all those things. The chances of spread of this virus from those surfaces is very, 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 very minimal. So for all practical purposes, it is the droplets arising from the patient of COVID-19 which cause infection to the opposite person.
Thank you, Dr. Sandeep. It looks like Dr. Vishwanath was able to join us. So, sir, would you like to shed some light on the much talked about variants of the virus which are now taking over the world, as it seems? Dr. Vishwanath? It looks like we have some sound issues there. Meanwhile, we'll have an audience a question sent in by viewers. At what point of the disease do we get the tests done? Is the question posted by one viewer. Dr. Balakrishna, would you like to shed some light on at what point a patient should decide to get their test done?
Any patient who is a primary contact with the patient, if any person who is suffering from the disease of COVID-19, if he comes into contact with them, he's called as a primary contact. If he develops fever, typically the incubation period starts from 5 to 7 days or maximum 10 days. During this period, if anybody develops fever, headache, body ache, throat pain, irritation in the chest, and difficulty in breathing, or sometimes they will have loss of taste, loss of smell. All these symptoms suggest of upper respiratory viral illness. We will call it as influenza-like symptoms. If these symptoms are there, we are advised to undergo the classic test, what is called nucleic amplification NAT, otherwise known as commonly called as RT-PCR of the nasal or pharyngeal liquids.
So, thank you, sir. Thank you for the clarity provided. Question back to Dr. Vishwanath regarding the variants of the virus. Sir, would you like to talk about the much talked about variants of the virus which are now gaining prominence around the world?
Yeah, as we all know, the viruses are peculiar in the way for the survival. They keep on changing their structures. It is not a new thing. Like we have seen even in influenza virus changing the structure because of mere survival. There have been several variations in the virus all over the world, and this doesn't stop at this moment. And there are certain variations that are very notorious. For example, to name a few, there is a variant of South African variant, which even the vaccine is not very efficacious to prevent. And therefore, the variations there at this moment will not bother much. But the thing is, when it comes to the vaccination and preventive strategies, variations of the viruses is very important. So I would like to comment in this way.
Thank you, sir. So, Dr. Gauri Shankar, would you like to shed some light on the natural history of the disease and at what point you encounter patients coming into the ICU? At what point in the disease do you encounter patients coming into the ICU? Dr. Gauri Shankar? Okay, so we'll have another question.
Hello.
Hello, yeah. Sir, can you hear me?
Am I
The
audible?
question was, at what
Yeah.
point in the natural history of the disease do you see the patients coming in? Would you like to shed some light on the natural history
Yeah.
as well as how severe are the cases that you see in the ICU?
Yeah, basically, once somebody gets exposed to a source, which could be their relative or in a community area or in the hospital, so initially 0 to 5 to 7 days is what is called as the incubation and symptomatic period start. So initially around 3 to 4 days they are asymptomatic, then start the symptoms. The symptoms persist for 5 to 7 days, and then slowly over the second week they start improving. This is one category. Almost 80% of the patients who are mild symptomatic and they recover. This 80% also includes asymptomatic cases. They don't even get to know that they have had a COVID illness. There are another 15 to 20% of patients who become severe. They could either become severe in the second week, or of late we are seeing in this second wave where patients are getting severe symptoms with moderate to severe disease in the late second week. By around 10 to 12th day, they become more severe with worsening symptoms of breathlessness, desaturation, severe diarrhea, and they present to hospital and often require ICU admission.
Okay, thank you, sir. So another question, time for a question from one of our viewers. The question is, if you are COVID positive, how do we decide whether to home quarantine or get hospitalized? And at what stage should a patient get hospitalized? Question to Dr. Sandeep.
Yeah, it is actually a very good practical question. Okay, you have got fever for 1 or 2 days, you got yourself tested, and you are turned out to be positive. Now, how do we decide whether you are going to be admitted in the hospital or whether you are going to be kept at home? Okay, this is a very good question. See, one thing I want to make it clear. See, the classification of COVID-19 severity is based upon pulse oximeter reading. Okay. So what is the oxygen saturation at your presentation to the hospital or to the doctor is what matters. And that is the parameter depending upon which we decide whether you are going to be getting admitted or whether you are going to be treated at home. Okay. So the initial pulse oximeter reading, okay, that is at rest as well as after exertion, that is after 5 minutes of maybe walking or minimal exertion, whatever is there. So after doing that, we take a reading of pulse oximeter, and if that reading is less than is more than 94, then you fall under mild category. Okay, and they are the people who will be decided to be sent back to home, and they will be treated as a home quarantine basis. The people who are from 90 to 94 of saturation after walking at presentation are classified as moderate COVID-19 infection, and they are the candidates who are to be admitted at the hospital. And people who have got a saturation of less than 90 will fall into severe category, and they also will be getting admitted to the hospital. One thing is very, very important. See, just because you are classified as mild and you are sent back home, that doesn't mean that you will remain mild. The chances of you progressing from mild to moderate and from moderate to severe are there. As Gauri Shankar was telling, it is basically a 2-week disease, and the chances of worsening are there throughout these 2 weeks. So for the once you get the symptom, you have to be very, very careful for up to at least 10 to 12 days. You have to monitor yourself. You have to keep yourself under isolation. You have to keep yourself under constant vigilance. Okay. For at least 10 to 12 days. So once you are decided that you are going to be sent home, we will be usually sending you home with a basic medications as well as a pulse oximeter with you. So it is your bound responsibility for the patients who are also sitting at home to monitor themselves and to ensure that they reach the hospital by the time they become by the time their severity changes from mild to moderate, rather than being at home that your doctor has told to you to be at home. You need not, you should not be negligent, or you should not forget that you have got a COVID infection, and it can progress in anybody. Okay, although the percentage of progression is less than 10%, but still whether you are falling in the 10% or in the remaining 90% is not in our hands. So it is your responsibility as a patient to monitor your own self by serial pulse oximetry readings. How frequently pulse oximetry readings? At least once in 6 hours is enough. See, don't keep on monitoring every 5 to 10 minutes and get unnecessary panic attacks. So once in 6 hours at rest as well as after walking, and if at all you feel that the saturation has dropped as compared to yesterday, then you should make it a point to contact your doctor and maybe reach a hospital at the earliest, so that we prevent you from going to meet Gauri Shankar in the ICU.
So
Next,
just to add one more point
yes.
to what Dr. Sandeep has said, there is a self-monitoring perform a guide box given in the Ministry of Health and Family Welfare. It's a very good chart. Anybody can go through it. It has a 6-hourly charting. Just anybody who is infected with COVID can download the chart and monitor themselves so that they don't miss anything and they don't miss red flag signs, so that they don't come to ICU. Yeah.
Next question is to Dr. Balakrishna. In this second wave, it has been found, or it is being speculated, that a large number of cases are actually being driven by the variants. So, sir, what do you have to say about the fact that the variants may be playing a great role in today's second wave? Question to Dr. Balakrishna.
No, I didn't get you because I lost.
So the question was, so in this second wave, it is being speculated that a large number of the cases are actually due to the new variants. So, what is your take or what is your opinion on this matter?
No, because of the mutant virus, what we see earlier, it is only one individual in the family used to get affected. But the current, current way causing, if one person get affected in the family, whole family members get affected and severely. The infectivity is very high in the current. That's because of mutation.
Okay, sir. So the next question is: once a person is, once a person is in a position that he needs to be admitted, like his saturation falls down to
Dr.
less
Siri,
than.
just a minute. Huh? Just a minute. See, I think other than the speaker, everybody should keep their phone in mute. Okay, I think there is some disturbance which is coming. I think that is, making us not to hear those statements. So everybody keep your phones in mute unless you are
Yeah.
talking.
So, question to Dr. Vishwanath. So, once a person is hospitalized, what are the treatment? What is the treatment that we follow? What are the protocols that we follow for a person in the ward? And
Yes.
how do we make sure that if once a person is in the ward, under what criteria he gets shifted to the ICU?
Okay. See, there have been many trials and errors because it's a new disease. Since the onset of the first wave, we have been trying various agents. But now, by far, the largest, we are of most certain that in the first few days of the symptoms, what I mean is first week of the symptoms, if somebody is presenting, I think it is the phase of viremia and it merits the advantage of giving antivirals. Though there are many other issues with antivirals, for example, oral favipiravir is there or remdesivir. Because remdesivir is not easily available and manufacturing delay and other things, we spare the remdesivir for those who have got mild hypoxemia, as Dr. Sandeep was defining. If the saturation is below 94%, for them we give remdesivir. And now the other molecules which were used in previously, for example, HCQS and other molecules are slowly getting receded back into the treatment. But I would like to mention that ivermectin, which was being used, is still being continued because of advantage that it has got an antiviral property. Doxycycline we are using, it is not because it is antiviral, because if it is the respiratory typical pneumonia, so if it is not due to COVID, then doxycycline will cover that. So with this intention, those people who are in the ward with normoxemia and having presented within 1 week of their onset of the symptoms, this is the standard of care we give. Second, if there is any onset of hypoxemia, we shift them on to the remdesivir. We administer the oxygen depending upon the severity of the hypoxemia. They can be kept in the ward with oxygen wards. And if beyond that, if they're worsening oxygen status beyond that, probably they are the best people to be handled in the ICU. Now the question comes when we are going to use. There are several experimental medications that are available, and some of them are also being under used as a emergency use. So we are not getting much of the idea about these molecules that are namely tocilizumab, then convalescent plasma therapy, and there are so many myriad of the molecules like bevacizumab, and there is the baricitinib. All these are still, we don't know the role, but they are mostly spared to those who are having profound hypoxemia and not to the one who are having a normoxia. You need not bother about this. The second thing I would like to think is this COVID infection is having a procoagulant state. So it is prudent for us to prevent the thrombosis. Many a time we have seen patients presenting to emergency with a stroke and also the myocardial infarction. So to prevent that these things happening, we have to use novel or oral anticoagulants, or if they are in the hospital, you can use any of the injectable anticoagulants. So these are the small bird view of what treatment is offered to them. And suppose if there is secondary bacterial infection, you need to choose the antibiotics if there is a need be, and depending upon the source of infection. Thank you.
Thank you, sir. In continuation with that question, so Dr. Gauri Shankar, once the person reaches ICU, how do you triage what level of the person requires? How much of oxygen support or artificial ventilatory support? How do you triage, and what is the usual modality of treatment in the ICU?
Okay. So what patients we are looking at recently is most of them come with what is known as severe hypoxia or desaturation. And according to the requirement of oxygen, or what we call as PF ratios, how much the saturation or oxygen content in the blood is and how much oxygen they are requiring, we categorize them into mild, moderate, and severe ARDS. So with the mild ARDS, people often tolerate and maintain a saturation with low level oxygen, low oxygen requirements. Generally, we give HFNC or non-reservoir breathing mask, or what mask with reservoir bag. So with that, they maintain. People with moderate to severe who require more oxygen with a pressure, so they are managed with what is called as non-invasive ventilation. And finally, those who are not tolerating non-invasive ventilation, who are having distress, that is even with say around 100% oxygen on non-invasive ventilation, they are in distress. That is, the respiratory rate is going beyond 35, 40. So they get fatigue by the end of 1 or 2 days. Then we switch on to invasive ventilation. So basically, people coming with severe hypoxia is one category. We also have got patients who come with severe dehydration because of diarrhea. Another category. Few people come with strokes. Few people come with cardiac events. Few people, 1 or 2 cases with severe cardiac involvement like myocarditis. So we have seen various kinds of people, but most of the ICU admissions are because of desaturation, and they are started on, either they are already on antivirals like remdesivir. If not, we start in the ICU if they are falling within the 10 days category. Other essential drugs, as Dr. Vishwanath sir already mentioned, they are started with anticoagulants and steroids as the mainstay of therapy. We continue the same. There is little modification hardly required. And then accordingly, we do inflammatory markers every 48 or 72 hours according to the progress, severity, and progress of the disease. We also check CT scans if required, or if it is not done, follow-up X-rays. We do ultrasound just to have a day-to-day variations, to have a look at variations in the lung status. And there are few experimental therapies, as sir said, and we go for those trial drugs only if we are not finding much progress with the routine standard of care.
Thank you, Dr. Gauri Shankar. In continuation with the theme of experimental drugs, Dr. Sandeep, what do you have to say about the newest entrants into this milieu, 2DG, and the combination of casirivimab and imdevimab? What impact do you think these new molecules will have on the existing treatment protocols? Is muted. Sir, you are muted.
Sorry. So as you all know, ours is a continuously evolving field actually. Since the onset of this pandemic, I think almost every 15 days or every 1 month, we have got some or the other new drug coming in and going out also. So personally speaking, see, personal experience with all these new drugs is not there. By the time they all came into market, the caseload had already come down in our center at least. So I don't have any first-hand experience of using this 2DG as well as this newer what is that cocktail, so-called cocktail which has come in. But what I feel is none of these drugs have made any kind of an impact on the mortality associated with COVID-19 before, I mean to say, after the steroids came in. Okay. So I don't think they have, altered the mortality by even 0.1% also. The mortality, whatever was there with the usage of steroids, continues to be the same. Okay. So let us try to keep it simple. Ours is a developing country. We have got a lot of, the majority of our population is not in a position to afford all these, newer these drugs. I'm not discouraging the usage of them, but still, majority of the people can be treated with very cheap, useful drugs if at all the patients come to us at the right time. So that is very, very important. So the timing of institution of therapy is important rather than what drug you are giving, because none of these drugs have proven to be, I mean, completely like a, what you say, Sanjeevani or something like that, which will cure the disease completely. Okay, everything has got its own advantages and disadvantages. The judicious and cautious usage of the drugs is required amongst us. So we as a team, actually majority of the time in our hospital at least, we all sit together before starting somebody on a new drug or some drug which is still in the experimental mode. So I don't have any first-hand experience with these two drugs, so I'll not be able to comment. But as far as the evidence says, as far as the papers have been published in the support of these two drugs, definitely they are shown to be beneficial in COVID-19 infection. But I don't have any first-hand experience using them, so I'll not be able to comment whether they are useful or not useful. But what one conclusion I can tell you is, if a proper institution of therapy is done at the right time, that is something which is going to save patients rather than the drug itself. Okay, so that's it from my side. Anybody wants to add anything? I am open to, please, Dr. Gauri Shankar.
Yeah, what Dr. Sandeep said is absolutely true, because as far as evidence is concerned, only steroids have had mortality benefit. Even the data regarding remdesivir is yet to come. There are so many trials underway. It reduces the hospital stay time to recovery. That is what is there. Some amount of mortality short term is also coming up. But one thing is that in the last season or last year, remdesivir was kind of experimental drug, but now it has become kind of standard of care. Not exactly, but it is still part of few guidelines, part of not part of few guidelines, but most of the physicians across India are using it. So what comes to guidelines is what actually gets published as evidence. So as of now, we are more dependent on the clinical experience of the treating physicians and treating doctors, because we cannot wait for the guidelines to come over. So meanwhile, if at all you feel a patient requires some experimental therapy who is not responding to these drugs, then we are trying these with the consent of relatives, and after having a discussion of the hospital committee, like as sir said, we all sit together discuss. So was the case with plasma. We had a few people receiving plasma. Of late, we have reduced. So coming back to all other experimental drugs like bevacizumab or tofacitinib and baricitinib, we are still using them because we have some clinical experience, and also there are no major side effects for us to hold these drugs back. So as a part of benefit of doubt to the patient and some published data, small studies, we are using them. But again, as said and done, timing is very important. Antiviral phase, inflammatory phase, we categorize the patients at what time they come. If they come in the early stage, antivirals are important. If they come in the inflammatory phase, we have immunomodulators. and late, or then if they present late, we are left with only rescue therapies like invasive ventilation or ECMO. That's it.
Thank you, sir. So next is a viewer question to Dr. Vishwanath. So what are the comorbidities which predispose a person to get severe COVID? A question posted by one of our viewers. The question is by one of our viewers to Dr. Vishwanath. What are the comorbidities which predispose
Madam,
to more
your voice was
infection?
breaking to me. Can I request you to repeat the question?
So the
Comorbidities?
question, which predispose to
Yes.
more severe COVID? That is the question.
Okay. Thanks, madam. Yeah. Comorbidities, you see, what we need to understand is if immune system is affected by any of the pre-existing medical condition, there the virus effect of the virus on them is high. So that is the correlation that we have regarding comorbidities. But that doesn't mean it's a rule of book that those who have got always the comorbidities should have the worst of the disease. That picture should not come in the mind. We have seen people who don't have the comorbidities, but still they developed a mild to moderate or severe disease. So comorbidities per se don't decide the fate of the patient. That's number one. But having said this question, I would like to enumerate certain comorbidities where we have to extra precautiously monitor them. That's all the responsibility of ours. For example, uncontrolled diabetes, chronic renal failure, congestive heart failures, those immunocompromised for either using of chemotherapeutic agents or the malignant conditions, and liver failures, kidney failures. So these are the patients we in many of the disease. It's not only pertaining to COVID. Many of the disease, if you see, you will get the same list. If you strike the button, you get the same list more or less. So these are the comorbid patients. We would be cautious and maybe more frequently we evaluate them for their progress. But having said that, it won't always destined to worse their condition. I hope I am clear on that.
Sir, one more point to add. See, according to me, see, as I totally agree with Dr. Vishwanath, what he told was, I mean, more or less accurate. I think, see, the comorbidities are only for monitoring. Just because you are having a comorbidity, that doesn't predispose you to the severe disease, and just because you don't have a comorbidity, that doesn't protect you from going into severe disease. Okay, it is just only for monitoring purpose to triage people. We have been using this comorbidity as a what to say as a guideline, as a guiding factor or something like that. According to our observation, see, obesity is a major comorbidity which is known to play a major detrimental role in COVID-19 infection. Apart from obesity, rest all are all only as a sir said, only, I mean, just to monitor the patients. But obesity is playing a major role in the outcome of COVID-19 infection. So through this, I would like to request everybody who is having obesity, who are overweight, if at all they get a COVID-19 infection, I think they are the ones who have to be monitored much more carefully as compared to the people with other comorbidities.
Thank you, Dr. Vishwanath and Dr. Sandeep. The next question from our viewer goes to Dr. Balkrishna. If a patient is COVID positive and admitted in the hospital and has been discharged, what are the remedies that they should do once they reach home? What all precautions should they take, them and their family members?
Well, am I audible? Because I've got a lot of glitches and
audible, sir.
Yeah. Okay. Once the patient recovered from the disease, the clinical recovery, usually if the symptom is mild to moderate, if they get discharged from the hospital, such patient, what precautions should be followed? Once they get discharged, they should not take a public transport to reach home. Number one. Number two, as soon as they reach home, they should have an isolated room exclusively for the personal isolation. and they should not share any bed, towel, and they should have exclusive washroom for themselves, and always wear mask, no visitors, no parties at home, and if at all, if they have completed after 1 week of isolation in the house, they can break this rule if they have mild disease. If it is a serious one, that is mild, severe cases, in such cases, the quarantine will be more than 10 to 20 days of quarantine should be mandatory. And as far as relatives are concerned, they should not come into contact with the person, and they also should wear the mask and frequent hand washings and sanitizing the touch surface and using hello. Okay. So there should not be any party at all at home.
Thank you, sir, for clarifying what one should do once they reach home. The next question goes to Dr. Gauri Shankar. So, what is your take on mucormycosis, the much talked about, delayed complication of COVID? Have you had occasion to see many cases of mucormycosis, and what is the treatment that you would offer to such patients?
Yeah, of late, the most talked topic over all the TV shows and in the magazines is this black fungus, also called mucormycosis, though it's a misnomer. But anyways, it's been creating a lot of awareness in and around. So even the guidelines have come up. So personally, from our ICU, we have hardly seen any case turning out to have mucor and coming back to us for the treatment, though we have got few cases from other hospitals. The postulated theories that why somebody gets mucor have been that generally people with uncontrolled diabetes or other immunosuppressive states who have received steroids in higher dose or for longer periods, plus who have had chronic sinusitis and other nasal issues. And there have also been few theories suggesting the use of humidifiers and all, which actually have been debunked to have not been related to this. So all these reasons, people are getting mucor cases. They present with basically swelling of the eyes, nasal sinuses, pain or loosening of teeth or pain in the teeth, sudden few headache and other symptoms. And they are usually coming up asymptomatic also. We have seen cases who have had extensive cerebral spread, but they have no any symptoms. So basically, they come to us late, and the treatment, as far as it is concerned, it is very difficult to treat because most of the cases require surgery or debridement. Only drug therapy is not enough for it to be managed. So usually they go to ENT surgeons or maxillofacial surgeons are required to clear off the mucor, and then you start them on drugs like amphotericin B, either conventional or liposomal, or posaconazole or isavuconazole, the new additions to the battery. But personally, I haven't seen any mucor cases in my ICU. So I would like to pass this question to whoever, probably Dr. Sandeep or Vishwanath, if they have come across any.
Yes.
Dr. Sandeep, would you
Sir,
like to shed some
Sandeep
light
sir
on
and myself, we have
mucormycosis?
seen a couple of.
Yes, please go ahead, Dr. Sandeep. Yeah.
ವಿಶ್ವನಾಥ್ ಸರ್ ಹೇಳ್ತಾ ಇದ್ರಲ್ಲ.
Actually,
Yeah, please
myself
go ahead,
and
Dr. Vishwanath.
Dr. Sandeep, both of us have been referred a few cases of pulmonary mucor, and we have been surprised to see such kind of a thing. But extensive involvement of a lung, we had to submit them for the surgery, and patients are doing well. And one more, today only Dr. Sandeep accomplished the bronchoscopy in the patient who had COVID pneumonia and this. See what previous wave also we had mucor, but it didn't make big noise because this wave the number of cases was 5 times more than the previous wave. Naturally, you will bound to get such a increased number of mucormycosis. It is nothing alarming to us. And what I would like to bring to kind attention, it is not contagious. That just because somebody is having mucor and you won't get the mucor by droplet or anything. So that fear should not be there in anyone. And the thing is, regarding the treatment, there is a lot of confusion was going on because the amphotericin B, liposomal B is not very much available. But equally, good medicines are available. People should not stick on to only amphotericin and they should not worry that this thing. And most other important is if it is a limited and limited to particular region, the best thing is to get the surgical excision completely, and that totally cures the condition. And follow-up period, the treatment goes with antiviral, as Dr. Gauri Shankar was mentioning, for a period of sometimes even 6 months, sometimes given up to 1 year as well, depending upon the response to the therapy. So it is not very unheard. It is common. I would like to add one more point here is that not only just mucor, we have been seeing aspergillosis also and candidemia, candidiasis also along with these. So all both black and white both are affecting, and that is because probably the COVID infection per se will make the devascularized area because of microthrombi and makes the nidus of infection to extensively grow and gives a saprophytic media for the fungus to grow. Probably that is one of the hypotheses. But source how it comes, there is myriad of theory which I don't want to go into the detail. Thank you, Sandeep sir. You have anything to add, sir?
Coming to the last but not the least topic of discussion, it's the vaccines. So India has been a forerunner in the manufacture of two vaccines, Covaxin, which is indigenously developed, and Covishield in collaboration with Oxford AstraZeneca. Dr. Sandeep, can you tell us what would you advise people to do? Should they take vaccine or not? Is there a preferred vaccine?
See, actually, people should take vaccine. There is no doubt about it. Okay. And both of them have been shown to be, equally effective, more or less. Covaxin has got at least 1 or 2%, maybe ups and downs might be there. But for all practical purposes, kindly vaccinate yourself. Whatever vaccine is available, please take it. And and if at all you are not getting vaccine, please don't panic all. Don't run here and there in search of vaccine and don't get scared that you're not getting vaccine. So even if you get the disease, if there is no problem, we are all here to treat you. The only thing what we request is to come early to the hospital before things go beyond our reach as well. So the conclusion is vaccinate yourself. Both Covishield and Covaxin can be, are equally efficacious. Okay. So whatever interval recommendation is released by the ICMR, follow those guidelines. And if you are not getting vaccine because of some logistic issues, don't panic. Okay. And wait till you get the vaccine and then get vaccinated. That's all.
Also, often asked question is once a single dose of vaccine is taken and if a person becomes COVID positive, when should he take the second dose of vaccine?
6 weeks from the recovery.
6 weeks from the recovery would be this thing. And another clarification is if at all the person has not taken vaccine at all and the person gets COVID, how much time he should wait to take the vaccine?
Again, the same thing. 6 weeks from the recovery is the ICMR guideline, whatever they have released. And again, there are a lot of places where there is a shortage of vaccine and all those things. See, ideally speaking, whenever a person gets naturally infected by a virus, the immunity is known to last long at least for 6 to 9 months. So, if at all you want to get vaccinated and you are getting the vaccine, you wait for 6 weeks and then get vaccinated. If you are not getting vaccine, don't worry, you will not get reinfected at least for the time being, at least for a period of 6 to 9 months. So, within that time, you can get yourself vaccinated.
So with this, we are bringing our session to a conclusion. So some of the take-home messages that I would like to reiterate is this. It is a novel disease. It is a learning process for both patients and the treating doctors. So what the patient should do is, once they become COVID, first of all, take all the precautions, avoid the 3 C's, that is avoid crowded places, avoid close contact, avoid confined places with no ventilation. That is the first and foremost precaution they should take. Continue wearing your mask, cleaning your hands with hand sanitizer. So only preventing infections is in your hands and your hands alone. So a patient should take all precautions possible. As far as treating doctors are concerned, we are always doing our best from the time the patient enters the hospital till the patient leaves the hospital. We are doing our best. But yes, it is not possible to always have a great result or a great outcome. Some patients do succumb. That is something that people should understand. And as far as vaccine is concerned, please take the vaccine if it is available to you. Do not give ears to hearsay and have unfounded beliefs about vaccine. Please take the vaccines and protect yourselves. So Dr. Balakrishna, any concluding remarks from your side? He's muted himself. Sir, you're muted.
Can you audible? Am I audible?
Yeah, some concluding remarks, sir. We have 2 more minutes left in the session.
Yeah. So almost we have covered almost all points. The concluding remark: the mainstay of therapy of COVID infection is right time, right dosage, use of steroid, oxygen, and vaccination. This is the correct management of COVID-19 infection.
Very big thank you for all our viewers for joining today's session, and thank you to the panelists for enlightening the viewers.
Madam, just a minute. Thank you, Dr. Siri, also for wonderfully moderating the session. I think she has, asked very valid questions, and hopefully we have answered it in a way the way she wanted us to answer. So thank you very much, madam. It was nice.
Thank you. Thank you, madam.
I would recommend all should be in the same room, because lot of glitches, audio visual is a lot of problems.
Yeah, we are promoting social distancing by staying in separate rooms. We are walking the talk.
I know, but no, I could not speak. I mean, I could not convey my words. A lot of disturbances and lot of breakdown in between. Okay. See, thank you.
Okay.
How are you, Dr.?
Thank you very much.
Thank you, sir.
Thank you.
Take care.
Thank you, everyone.
I'm fine. Fine, sir.